Course 96. What is pleural effusion? A196. A pleural effusion is the abnormal accumulation of fluid between the two layers of the pleura, the thin membrane that covers the lungs and lines the inside of the chest cavity. Q197. What are the common causes of pleural effusions? A197. The most common causes are congestive heart failure, pneumonia, malignancy, and cirrhosis. Q198. How do the characteristics of the pleural fluid help determine the cause? A198. Analysis of the pleural fluid, including appearance, cell count, protein, and LDH levels, can help distinguish between different types of effusions. Q199. What is a transudative pleural effusion? A199. A transudative effusion is caused by an imbalance in fluid production and absorption, often due to systemic conditions like heart or liver disease. Q200. What is an exudative pleural effusion? A200. An exudative effusion is caused by increased permeability of the pleural surfaces, often due to inflammation or malignancy. Q201. How does the Light's criteria help differentiate transudates from exudates? A201. If the pleural fluid to serum protein ratio is 0.5 or the pleural fluid to serum LDH ratio is 0.6, the effusion is classified as an exudate. Q202. What is the role of pleural fluid cytology in the diagnosis of pleural effusions? A202. Cytological examination of the pleural fluid can help detect the presence of malignant cells, aiding in the diagnosis of a malignant effusion. Q203. When is a pleural biopsy indicated? A203. Pleural biopsy may be necessary if the initial evaluation, including fluid analysis, does not reveal the cause of the effusion. Q204. What is the treatment for a transudative pleural effusion? A204. The underlying condition causing the transudative effusion, such as heart failure or liver disease, should be treated. Q205. What is the treatment for an exudative pleural effusion? A205. Treatment depends on the underlying cause, which may involve antibiotics, chemotherapy, or surgical intervention. Q206. What is a parapneumonic effusion? A206. A parapneumonic effusion is a pleural effusion that occurs in association with pneumonia or another infectious process in the lung. Q207. How do parapneumonic effusions differ from other exudative effusions? A207. Parapneumonic effusions tend to have a lower pH, higher LDH, and higher cell counts compared to other exudative effusions. Q208. When is a chest tube indicated for a parapneumonic effusion? A208. Chest tube drainage is typically required for complicated parapneumonic effusions with low pH, high LDH, or evidence of loculation. Q209. What is a malignant pleural effusion? A209. A malignant pleural effusion is an accumulation of fluid in the pleural space caused by the spread of a malignant tumor, most commonly from lung cancer or metastatic disease. Q210. How is a malignant pleural effusion managed? A210. Treatment options include thoracentesis, pleurodesis, indwelling pleural catheters, and occasionally surgical interventions like pleurectomy. Q211. What is a chylothorax? A211. A chylothorax is the accumulation of lymphatic fluid, chyle, in the pleural space, usually due to a disruption of the thoracic duct. Q212. What are the common causes of a chylothorax? A212. The most common causes are trauma, malignancy, and congenital abnormalities of the lymphatic system. Q213. How is a chylothorax managed? A213. Initial management involves thoracentesis, followed by dietary modifications, low-fat diet or total parenteral nutrition, and, if needed, surgical intervention to ligate the thoracic duct. Q214. What is a hemothorax? A214. A hemothorax is the accumulation of blood in the pleural space, often due to trauma or underlying vascular abnormalities. Q215. How is a hemothorax managed? A215. Immediate drainage of the pleural space and identification to treatment of the underlying cause, which may require surgery, are essential. Q216. What is the role of pleural manometry in the management of pleural effusions? Q221. What is sleep apnea? A221. Sleep apnea is a sleep disorder characterized by repeated pauses in breathing during sleep, leading to fragmented, poor-quality sleep. Q222. What are the main types of sleep apnea? A222. The two main types are obstructive sleep apnea, OSA, and central sleep apnea, CSA. Q223. What are the risk factors for obstructive sleep apnea? A223. Obesity, male gender, older age, large neck circumference, and craniofacial abnormalities are the main risk factors for OSA. Q224. What are the symptoms of obstructive sleep apnea? A224. Loud snoring, witnessed breathing pauses, excessive daytime sleepiness, and morning headaches are common symptoms of OSA. Q2225. How is obstructive sleep apnea diagnosed? A2225. Overnight polysomnography, sleep study, is the gold standard for diagnosing OSA by measuring breathing patterns and oxygen levels during sleep. Q226. What is the apnea-hypopnea index, AHI, and how is it used to diagnose OSA? A226. The AHI is the number of apnea and hypopnea events per hour of sleep, and AHI.5 is diagnostic for OSA, with severity classified as mild, 5 to 15, moderate, 15-30, or severe, 30. Q227. What is the treatment for mild to moderate obstructive sleep apnea? A227. First-line treatment is usually positive airway pressure, CPAP, therapy, which keeps the airway open during sleep. Q228. What are the alternatives to CPAP for treating obstructive sleep apnea? A228. Alternatives include oral appliances, weight loss, positional therapy, and surgical options like uvulopalato-pharyngoplasty, UPPP. Q229. What is the role of weight loss in the management of obstructive sleep apnea? A229. Significant weight loss can dramatically improve or even resolve OSA in overweight obese patients. Q230. What is central sleep apnea and how does it differ from obstructive sleep apnea? A230. Central sleep apnea is caused by the brain's failure to signal the muscles to breathe rather than physical obstruction of the airway. Q231. What are the common causes of central sleep apnea? A231. Heart failure, stroke, opioid use, and high-altitude exposure are common causes of central sleep apnea. Q232. How is central sleep apnea treated? A2232. Treatments include positive airway pressure, CPAP, BiPAP, oxygen therapy, and treatment of the underlying cause, e.g. heart failure management. Q233. What is Cheney-Stokes respiration, and how is it related to central sleep apnea? A233. Cheney-Stokes respiration is a pattern of alternating periods of deep and shallow breathing, often seen in patients with central sleep apnea and heart failure. Q234. What is the relationship between sleep apnea and cardiovascular disease? A234. Obstructive sleep apnea is an independent risk factor for hypertension, coronary artery disease, heart failure, and stroke. Q235. How does sleep apnea affect daytime functioning? A235. Excessive daytime sleepiness, impaired cognitive function, and increased risk of motor vehicle accidents are common consequences of untreated sleep apnea. Q236. What is the role of home sleep apnea testing in the diagnosis of sleep apnea? A236. Home sleep apnea tests can be used to diagnose OSA in patients with a high pretest probability, avoiding the need for full in-lab polysomnography. Q237. What is the significance of oxygen desaturation in sleep apnea? A237. Significant oxygen desaturation during sleep apnea. Events can lead to oxidative stress and cardiovascular complications. Q238. How does sleep apnea affect pregnancy? A238. Untreated sleep apnea in pregnancy is associated with increased risks of gestational hypertension, preeclampsia, and adverse fetal outcomes. Q239. What is the role of positional therapy in the management of obstructive sleep apnea? A239. Positional therapy, such as using a device to keep the patient on their side during sleep, can be effective for patients with positional OSA. Q241. What is asthma? A241. Asthma is a chronic inflammatory disorder of the airways characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and underlying inflammation. Q242. What are the common symptoms of asthma? A242. Wheezing, coughing, chest tightness, and shortness of breath are the hallmark symptoms of asthma. Q243. What are the main triggers for asthma symptoms? A243. Common triggers include viral infections, allergens, exercise, cold air, stress, and certain medications. Q244. How is asthma classified based on severity? A244. Asthma is classified as intermittent, mild persistent, moderate persistent, or severe persistent based on symptoms and lung function. Q245. What are the key components of the asthma pathophysiology? A245. Airway inflammation, airway hyperresponsiveness, and reversible airflow obstruction are the key features of asthma pathophysiology. Q246. What is the role of eosinophils in asthma? A246. Eosinophils are the predominant inflammatory cells in the airways of many asthma patients and play a central role in the disease process. Q247. How do pulmonary function tests help diagnose and monitor asthma? A247. Spirometry, which measures airflow, is used to diagnose asthma and assess its severity. Reversibility of airflow obstruction with bronchodilators is a key diagnostic feature. Q248. What is the role of bronchial provocation testing in asthma? A248. Bronchial provocation testing, using agents like methacholine or exercise, can help diagnose asthma in patients with normal spirometry. Q249. What is the role of exhaled nitric oxide, FeNO, testing in asthma? A249. Measurement of exhaled nitric oxide can provide information about airway inflammation and guide asthma management. Q250. What is the goal of asthma treatment? A250. The primary goal of asthma treatment is to achieve and maintain control of symptoms, prevent exacerbations, and minimize side effects of medications. Q251. What are the main classes of medications used to treat asthma? A251. Inhaled corticosteroids, bronchodilators, short-acting and long-acting, leukotriene modifiers, and biologic agents are the main asthma medications. Q252. How do inhaled corticosteroids work in the management of asthma? A252. Inhaled corticosteroids reduce airway inflammation, which is the underlying cause of asthma symptoms. Q253. What is the role of short-acting bronchodilators in asthma? A253. Short-acting beta agonists, e.g. albuterol, are used for quick relief of asthma symptoms and as needed for symptom control. Q254. What is the role of long-acting bronchodilators in asthma? A254. Long-acting beta agonists, LABAs, and long-acting muscarinic antagonists, LAMAs, are used for long-term control and prevention of asthma symptoms. Q255. When are leukotriene modifiers used in the treatment of asthma? A255. Leukotriene modifiers, such as montelukast, are used as an alternative or add-on therapy, particularly in patients with aspirin-exacerbated respiratory disease. Q256. What are biologic agents, and how are they used in asthma? A256. Biologics are monoclonal antibodies that target specific inflammatory pathways. They are used for severe uncontrolled asthma, particularly in patients with type 2 inflammation. Q257. What is the role of immunotherapy in the management of asthma? A257. Allergen immunotherapy, such as subcutaneous or sublingual immunotherapy, can help reduce symptoms and medication needs in patients with allergic asthma. Q258. How does asthma management differ in children compared to adults? A258. Asthma management in children often focuses more on preventing exacerbations and minimizing the impact on growth and development. Q259. What is the role of patient education and self-management in asthma? A259. Empowering patients with asthma education, self-monitoring, and an asthma action plan is crucial for achieving optimal asthma control. Q61. What is chronic obstructive pulmonary disease, COPD? A261. COPD is a progressive lung disease characterized by persistent respiratory symptoms and airflow limitation due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. Q262. What are the main types of COPD? A262. The two main types of COPD are emphysema and chronic bronchitis, although most patients have a combination of both. Q263. What are the primary risk factors for COPD? A263. Cigarette smoking is the leading risk factor, but exposure to other environmental pollutants, occupational dusts and chemicals, and genetic factors can also contribute to COPD development. Q264. What are the common symptoms of COPD? A264. Chronic cough, excessive mucus production, dyspnea and wheezing are the hallmark symptoms of COPD. Q265. How is COPD diagnosed? A265. Spirometry, which measures airflow limitation, is the primary diagnostic test for COPD. A post-bronchodilator FEV1-FVC ratio less than 0.70 confirms the presence of persistent airflow obstruction. Q2166. How is COPD classified by severity? A2166. COPD severity is classified based on the degree of airflow limitation as measured by FEV1 into mild, moderate, severe, and very severe stages. Q267. What is the role of chest imaging in the diagnosis of COPD? A267. Chest radiography and CT scanning can help identify the presence and extent of emphysema and other structural changes associated with COPD. Q268. What are the main goals of COPD management? A268. The primary goals are to reduce symptoms, prevent and treat exacerbations, improve exercise tolerance and slow the progression of the disease. Q269. What are the main classes of medications used to treat COPD? A269. Bronchodilators, short-acting and long-acting, inhaled corticosteroids, and combination inhalers are the mainstays of COPD pharmacotherapy. Q270. What is the role of long-acting bronchodilators in COPD? A270. Long-acting bronchodilators, including long-acting beta agonists, LABAs, and long-acting muscarinic antagonists, LAMAs, are the cornerstone of maintenance treatment for COPD. Q271. When are inhaled corticosteroids used in the management of COPD? A271. Inhaled corticosteroids are typically used in combination with long-acting bronchodilators for patients with moderate to severe COPD and a history of exacerbations. Q272. What is the role of oxygen therapy in COPD? A272. Supplemental oxygen therapy is indicated for COPD patients with resting hypoxemia to improve survival and quality of life. Q273. What is the significance of exacerbations in the management of COPD? A273. Exacerbations, or acute worsening of symptoms, are important events in the natural history of COPD as they contribute to disease progression and increased mortality. Q274. How is an acute COPD exacerbation managed? A274. Treatment typically involves bronchodilators, corticosteroids, and antibiotics if there are signs of infection along with supportive care. Q275. What is the role of pulmonary rehabilitation in COPD? A275. Pulmonary rehabilitation, including exercise training, education, and nutritional counseling, is a key component of comprehensive COPD management. Q276. When is lung volume reduction surgery considered for COPD? A276. Lung volume reduction surgery may be an option for selected patients with severe upper lobe predominant emphysema who do not respond to medical therapy. Q2177. What is the role of lung transplantation in the management of COPD? A277. Lung transplantation is a treatment option for carefully selected patients with end-stage COPD who meet specific eligibility criteria. Q278. How does COPD affect cardiovascular comorbidities? A278. COPD is associated with an increased risk of cardiovascular diseases such as coronary artery disease, heart failure, and arrhythmias. Q281. What is acute respiratory distress syndrome, ARDS? A281. ARDS is a life-threatening condition characterized by widespread inflammation in the lungs, leading to impaired gas exchange and respiratory failure. Q282. What are the common causes of ARDS? A282. The leading causes are pneumonia, sepsis, aspiration, trauma, and various other conditions that directly or indirectly injure the lungs. Q283. What are the clinical features of ARDS? A283. Rapid onset of respiratory symptoms, such as dyspnea, tachypnea, and hypoxemia, along with bilateral opacities on chest imaging, are characteristic of ARDS. Q284. How is ARDS diagnosed? A284. ARDS is diagnosed based on the Berlin definition, which includes acute onset, bilateral opacities, origin of edema, and impaired oxygenation. Q285. How is ARDS classified by severity? A285. ARDS is classified as mild, moderate, or severe based on the degree of hypoxemia as measured by the PaO2-FiO2 ratio. Q286. What are the key pathophysiological changes in ARDS? A286. ARDS involves an inflammatory cascade that leads to increased vascular permeability, alveolar edema, and surfactant dysfunction, ultimately impairing gas exchange. Q287. What is the role of mechanical ventilation in the management of ARDS? A287. Protective mechanical ventilation strategies, including low tidal volumes and positive end expiratory pressure, PEEP, are the mainstay of ARDS management. Q288. What is the concept of baby lung in ARDS? A288. The baby lung refers to the reduced functional lung volume in ARDS, which necessitates the use of lower tidal volumes to avoid further lung injury. Q289. What is the role of prone positioning in ARDS? A289. Prone positioning can improve oxygenation and outcomes in patients with moderate to severe ARDS by redistributing lung perfusion and ventilation. Q290. What is the role of extracorporeal membrane oxygenation, ECMO, in ARDS? A290. ECMO may be considered for severe refractory ARDS cases when conventional mechanical ventilation is unable to provide adequate oxygenation and ventilation. Q291. What is the role of pharmacological therapies in ARDS? A291. Pharmacological interventions, such as neuromuscular blockade, corticosteroids, and anti-inflammatory agents, have had limited success in improving outcomes in ARDS. Q292. What is the role of fluid management in ARDS? A292. A conservative fluid management strategy aimed at avoiding fluid overload has been shown to improve outcomes in ARDS patients. Q293. What is the significance of barotrauma in ARDS? A293. Barotrauma, such as pneumothorax or pneumomediastinum, can occur as a complication of mechanical ventilation in ARDS and worsen the patient's condition. Q294. What is the role of lung protective ventilation in ARDS? A294. Lung protective ventilation, using low tidal volumes and appropriate PEEP, is the cornerstone of ARDS management to minimize further lung injury. Q295. What is the long-term prognosis for survivors of ARDS? A295. ARDS survivors often experience long-term sequelae, such as impaired pulmonary function, neurocognitive deficits, and reduced quality of life. Q296. What is the role of rehabilitation in the management of ARDS survivors? A296. Early mobilization, physical therapy, and comprehensive rehabilitation are important for improving functional outcomes and quality of life in ARDS survivors. Q297. What is the significance of ventilator-associated lung injury, VALI, in ARDS? A297. VALI, caused by excessive stretch and pressure from mechanical ventilation, can further exacerbate the existing lung injury in ARDS patients. Q298. What is the role of biomarkers in the diagnosis and management of ARDS? A298. Emerging biomarkers, such as plasma proteins and inflammatory mediators, may help in the early diagnosis, risk stratification, and monitoring of ARDS. Q299. How does ARDS differ from other forms of acute respiratory failure? A299. ARDS is distinguished by the presence of diffuse alveolar damage. Q301. What is pulmonary hypertension? A301. Pulmonary hypertension, PH, is a condition characterized by an elevated pulmonary artery pressure, leading to right ventricular dysfunction and, if untreated, heart failure. Q302. What are the main types of pulmonary hypertension? A302. The main types are 1. Group 1. Pulmonary arterial hypertension, PAH. 2. Group 2. PH due to left heart disease. 3. Group 3. PH due to lung diseases. 4. Group 4. Chronic thromboembolic PH. And 5. Group 5. PH with unclear or multifactorial mechanisms. Q303. What are the common causes of pulmonary arterial hypertension, PAH? A303. Common causes of PAH include idiopathic, heritable, drug-induced, and those associated with conditions like connective tissue diseases, HIV, and congenital heart diseases. Q304. What are the typical symptoms of pulmonary hypertension? A304. Shortness of breath, fatigue, chest pain, syncope, and peripheral edema are the most common symptoms of pulmonary hypertension. Q305. How is pulmonary hypertension diagnosed? A305. Echocardiography is the initial screening tool, followed by right heart catheterization to confirm the diagnosis and determine the hemodynamic severity. Q306. What is the role of biomarkers in the diagnosis and management of pulmonary hypertension? A306. Biomarkers like brain natriuretic peptide, BNP, and troponin can provide prognostic information and guide treatment decisions in pulmonary hypertension. Q307. How is pulmonary hypertension classified by severity? A307. Pulmonary hypertension is classified into 4 functional classes based on the patient's symptoms and exercise tolerance. Q2008. What is the role of vasoreactivity testing in the management of pulmonary arterial hypertension? A308. Acute vasoreactivity testing, typically with inhaled nitric oxide, can identify a subset of PAH patients who may respond well to calcium channel blocker therapy. Q309. What are the main treatment options for pulmonary arterial hypertension? A309. Treatment includes targeted therapies like prostacyclins, endothelin receptor antagonists, phosphodiesterase 5 inhibitors, and soluble guanylate cyclase stimulators. Q310. When is combination therapy used in the treatment of pulmonary arterial hypertension? A310. Combination therapy, using 2 or more targeted therapies, is often used in patients with more advanced or progressive PAH to improve outcomes. Q311. What is the role of anticoagulation in the management of pulmonary hypertension? A311. Anticoagulation is recommended for certain subgroups of pulmonary hypertension patients, such as those with chronic thromboembolic pulmonary hypertension. Q312. What is the significance of right ventricular function in pulmonary hypertension? A312. Preservation of right ventricular function is a key determinant of prognosis in pulmonary hypertension, as right heart failure is the leading cause of death. Q313. What is the role of oxygen therapy in the management of pulmonary hypertension? A313. Supplemental oxygen is an important supportive measure to improve oxygenation and reduce the workload on the right ventricle. Q314. What is the role of diuretics in the management of pulmonary hypertension? A314. Diuretics are used to manage fluid overload and right heart failure in patients with pulmonary hypertension. Q315. What is the significance of exercise testing in the evaluation of pulmonary hypertension? A315. Exercise testing, such as the 6-minute walk test, can provide valuable information about functional capacity and disease severity in pulmonary hypertension. Q316. What is the role of lung transplantation in the management of pulmonary hypertension? A316. Lung transplantation may be considered for selected patients with end-stage pulmonary hypertension who have failed medical therapy. Q317. What is the prognosis for patients with pulmonary hypertension? A317. The prognosis for pulmonary hypertension varies depending on the underlying cause and severity. Q321. What is interstitial lung disease? A321. Interstitial lung disease, ILD, refers to a group of lung disorders characterized by inflammation and/or fibrosis of the lung interstitium, leading to impaired gas exchange. Q322. What are the main types of interstitial lung disease? A322. The major types include idiopathic pulmonary fibrosis, IPF, connective tissue disease-associated ILD, hypersensitivity pneumonitis, sarcoidosis, and occupational environmental ILDs. Q323. What are the common symptoms of interstitial lung disease? A323. Shortness of breath, dry cough, and exercise intolerance are the most common symptoms of ILD. Q324. How is interstitial lung disease diagnosed? A324. Diagnosis involves a combination of clinical history, physical examination, pulmonary function tests, imaging studies, chest X-ray, high-resolution CT scan, and often lung biopsy. Q325. What is the role of high-resolution CT, HRCT, in the diagnosis of ILD? A325. HRCT is a crucial diagnostic tool as it can identify characteristic patterns of lung injury and fibrosis that help differentiate between various ILD subtypes. Q326. What is the significance of lung biopsy in the diagnosis of ILD? A326. Lung biopsy may be necessary in some cases to confirm the diagnosis, especially when the HRCT findings are inconclusive. Q327. How is idiopathic pulmonary fibrosis, IPF, diagnosed? A327. IPF is diagnosed when other known causes of ILD have been excluded, and the HRCT shows a usual interstitial pneumonia, UIP pattern. Q328. What are the main treatment options for interstitial lung disease? A328. Treatment typically includes anti-inflammatory and anti-fibrotic medications, oxygen therapy, and in some cases, lung transplantation. Q329. What is the role of anti-fibrotic medications in the management of IPF? A329. Anti-fibrotic agents, such as pirfenidone and nintedanib, are the mainstay of treatment for IPF, as they can slow the progression of the disease. Q330. What is the significance of acute exacerbations in the course of interstitial lung disease? A330. Acute exacerbations, characterized by rapid worsening of symptoms and radiographic findings, are associated with high mortality in patients with ILD. Q331. How does the management of ILD differ in the acute versus chronic setting? A331. Acute management focuses on identifying and treating the underlying cause, providing supportive care and preventing further lung injury, while chronic management aims to slow disease progression. Q332. What is the role of supplemental oxygen in the management of ILD? A332. Oxygen therapy is an important supportive measure to improve oxygenation and exercise tolerance in patients with ILD. Q333. When is lung transplantation considered for patients with interstitial lung disease? A333. lung transplantation may be an option for selected patients with advanced, progressive ILD who have failed medical therapy and have no other significant comorbidities. Q334. What is the prognosis for patients with interstitial lung disease? A334. The prognosis for ILD varies widely depending on the specific subtype, with IPF generally having the poorest prognosis among the ILD subtypes. Q335. What is the role of pulmonary rehabilitation in the management of ILD? A335. Pulmonary rehabilitation, including exercise training and education, can help improve exercise capacity and quality of life in patients with ILD. Q36. How does the management of ILD differ in the pediatric population? A326. Pediatric ILDs often have different underlying etiologies and may require specialized treatment approaches compared to adult ILDs. Q337. What is the significance of environmental and occupational exposures in the development of ILD? A337. Exposure to certain environmental and occupational agents, such as organic dusts, inorganic dusts, and fumes, can lead to the development of specific types of ILD.